Yeah, so when I was given this topic, I was really unsure of how to approach it. And so most of my work today actually that I'm going to present is only because we work in one of the few centers that actually give disease modifying therapy, maybe one of 5 centers in the whole of India. But the reason I'm actually talking to all of you about this is because the largest number of disease modified children are actually in Kerala. So what are we actually doing with these children and how do we approach this? So usually when people talk about element, you're talking about from the anterior horn cell, you go down to your nerve, neuromuscular junction, and your muscle is actually your mimics. Now the reason why you talk about element is mainly because this is certain population is curable, treatable, whereas the rest are not. So I'm actually going to talk to you about what I really like doing right now is your disease modifying therapy. So in terms of SMA, I'm going to tie all of this to the shoulder, which is I think the harder part. So in an era of disease modifying therapy, why are you talking about scoliosis in a shoulder topic? Simply because all of the papers again are post 2021. So these are your recent advancements in terms of neuromuscular disease. And so most of us see children with spinal curves. If you're treating a child from 0 to 15 degrees, most often people don't do anything. But actually at this stage, one of the good interventions that you can really do is make modifications in their devices. So their seating devices or their postural devices, and this will actually help prevent your progression of curve. And why this eventually ties out to your shoulder is because it was found to affect shoulder function, and I'll describe to you as we go how it finally affects the shoulder. So one of the devices that actually we started using are your body compression suits. We unfortunately don't have data on this. There are 2 Indian manufacturers for this, because if you're trying to import this, the same thing that costs about 7,000 INR will cost you 25,000 if you're going to get it imported. As you start prescribing this, you will sort of discover the biomechanics behind it and see if your PNOs can actually start making these. These are very, very simple things. The last child is SMA type 2. She is post-disease modified, and the foam that she's actually sitting in was created by her mom, a very enthusiastic physiotherapist mom who really teaches us a lot. So this is something that you can get your PNOs to make quite easily, and this is something that we do in our center. So after 15 to about 45 degrees, the guideline says brace. So your TLSO, one of the unfortunate things is, because these children have learned to sort of be in a state of modified balance, I must say, once you shift the center of gravity, they find it very hard to hold their neck. So this needs, again, retraining as you go on. If you see, so this is why the shoulder plays an important role here. So you can see this child with scoliosis, you can see how the shoulder is. And what happens, it becomes quite difficult for them to use their upper limb. And so you're talking about going from your basic ideal to feeding to being able to transfer. So this is why preventing progression of this curve, and finally also you're dealing with a lot of operative complications. So the number of children who are actually offered surgery is very, very limited in our country. So this is something I feel like most of us know, physical therapy and whatever disease modifications do affect your rehab outcomes. Now, the whole point with this is, how many of us actually see these children? How many of us actually treat these children? Because what happens is they go to the physiotherapist. So a lot of the children who come from other states to Bangalore, actually they get disease modified, they go back home and they go back to you guys for continuation of care. Now what happens is sometimes they might go to the therapist and then they disappear. And they come back to us with deformities despite being disease modified. So it's not that we found a cure for this, but we still have to sort of monitor, all the deformities that we're seeing, because there is still intervention at every phase. I don't have an Indian picture for you because we aren't doing this yet here, but I'm sure a lot of centers use functional electrical stimulation, right? Like everybody talks about this. So one of the things that this child here, he is disease modified, he's still getting risdiplam. So one of the things that this parent does is, if you see, actually this child is on a balance board, he is getting functional electrical stimulation while doing an activity. So why not actually do this here? This is something that we are hoping to try. And one thing that we're really lacking is the children who come back for follow-up. So we don't have a child who comes in for a program treatment in terms of therapy. So we haven't tried this. So one of the things that you all can do as a population is, if you're seeing these children, maybe start doing this, and we can hopefully have collaborative data on this. So finally, this is something that we all learn in our textbooks, right? Adaptive devices. So a couple of weeks ago, I saw a 10-year-old child, congenital myopathy, not SMA, but she does very well. She's completely mobile, independent in terms of her mobility on a motorized wheelchair. She plays wheelchair football once a week, goes to school, loves to read, and all of that. And her spine, I think her Cobb's ankle was about 40, and so we're like, oh no. So she actually her wheelchair is brilliant. So we saw her only a year ago, and her curve had progressed so much that she needs a brace. So what had happened was, she had outgrown her modifications in the wheelchair, and nobody bothered to correct those modifications to her growth. And so one of the ways she eats is, because of the scoliosis also, she's not able to do this, right? So she has to bring her shoulder to the table and has to eat like this. So we said, okay, there are devices, why not, So I showed her all of the assistive devices that I knew, and she and the family said no. So finally it comes down to aesthetics as well. So this is where I feel like we know how the muscle works, we know the disease, and we also know how to create things. So I feel like while we accept devices that exist, we can also be creating other devices. The other tie-in in terms of prediction of loss of ambulation of DMD. So most of us are concerned with DMDs and Beckers until they stop walking, and after that we're like, what do we do? They're all wheelchair bound, right? So the upper limb is actually quite a useful tool in terms of predicting when this child is going to sit. Unfortunately, as a team, we offer a lot of options until the child is ambulant in terms of their casting, assistive devices, and then the wheelchair. And after that, nobody knows what to do with them. So as part of our, in order to do a clinical trial, you need to have your functional outcome measures. And if you've seen any of our children, they come to you with a whole booklet, and that every 6 months is just your functional outcomes. And so unless we trend this, I don't know if some physiatrists like to prescribe steroids. So our steroid dose is also dependent on your functional outcome measures. And so this is just the pull test. So what I'm trying to show here is how important the upper limb is for us to document your functional outcome measure. And so this is just one of the tests that you check the whole upper limb. So you're checking shoulder, elbow, and hand. So pain. I think pain is like the hottest topic in PMR for most people. But what happens when you take pain from a general population to a population with FSHD? So your facioscapulohumeral dystrophy, I've seen 3 adults, and all 3 adults have come with pain. And as a team, you decide, okay, we ultrasounded a lot of the myofascial trigger points, and so have any of us done this for FSHD particularly? Do we know how the trigger point looks in terms of a background of already a diseased muscle? And can we actually intervene at this stage? So trigger points are quite commonly injected. A lot of people do prolotherapy and all of that. But unfortunately, as a team, we say, shall we try trigger point? And then everybody looks in terms of, even the neuromuscular therapist, physician and the therapist, they say maybe we can try TENS. So this is the team of people who should probably look at these things and say maybe we can try trigger point injections. So this is a normal muscle. It's not your dystrophied muscle. So the architecture is going to be very different. Can we actually identify trigger points in this population? I don't know. Taping is something that actually we have tried. A lot of people like using it. I personally like it in certain conditions, but it was found to have no use at all in terms of translating to function in this population. So finally, what was described is your scapular. This procedure, actually, I've not seen any child get this procedure, mainly because one is doing it in India, you need a surgeon to be willing to do it, and also your outcomes of this. There's no proof that every child you send is going to actually do well with this. So this is a stage of children that progress to adults. Most of them do well until they become sitters. So the other thing is, in terms of as they grow bigger, they're bigger, and to transfer them becomes a big headache. Now, out of 10 of the adults whom we sort of prescribe the transfer devices, maybe 3 of them would have bought it and maybe 1 of them will use it. So this is another problem that we actively face in terms of how do you make these people who cognitively are still sound try to be independent. So these are things I'm actually posing more problems than solutions. So my last sort of wrap in is going back to your element condition of GBS. Basically what I want to highlight is this was a young boy who came from Kerala. He was admitted with us with GBS. In the month of March, he had moderate degree of sensory motor demyelinating disease. A month later, that became severe. But this is, again, he received all of the IVIG and everything. And so what I really want to show is that it might take a while before we actually do better. So this is him actually 6 months after. One of the things for us to remember is, the reason why this is important is, if they are not treated, they don't receive treatment, their deformities are not fixable. Once your bony deformity is set in, there's not much that we can do. So making sure the spine is supported, their axial is supported, and you're taking care of their distal weakness is also very important. So this is my team that we presented at World Muscle Society. And finally, all I want us to do is think of ideas that if you see these children, don't send them away, don't treat them as palliative, and hopefully we can actually give treatment advice and come up with new things. So, thank you.
Nice presentation. Next, we'll move on to the next topic. Next topic is shoulder pain and ergonomics by Dr. Keshavada.